So for those of you who have not been here before, I want to welcome you to the Appalachia Partnership Consortium meeting. For those of you who have not been here before, we don't use slides. We use conversation and dialogue. That is why Lynn is laughing already, like, girl, you don't know which way this could go. It could go left, it could go right, but we're going to have fun all night. So one of the most amazing things that kind of happened is that we, community education group and other community partners, have really been tasking the President's Advisory Council on HIV and AIDS to come to Appalachia. And it was our great honor when the White House and President's Advisory Council and HHS did something that I just frankly did not think was humanly possible. They changed and moved the entirety mass of the government because the last month's meeting was actually supposed to be a virtual meeting, and they did it in person in Charleston at the University of Charleston. So I want to thank all of the people from PACHA, from HHS, and from the CEG team, and from other community-based organizations who did the heavy lift to honestly to make that happen. Now that has happened, we've made some requests of PACHA and of HHS, which I'll go into later. But I really wanted to give folks who may not have been in the room an opportunity to hear from members of the President's Advisory Council, but also to hear from some of those folks that presented about local programs, about local research and data, and how important that is going to be for us moving forward. So the first kind of person I want to introduce you to is Dr. Philip Chen. Now, I had the pleasure of meeting Dr. Chen. I just think that Dr. Chen is like, remember Marcus Welby, MD? Most of y'all are not old enough to probably remember the TV show Marcus Welby, MD. But I'm like, man, if there was a TV doc, it needs to be Dr. Philip Chen. I'm like, he could be on CNN. He could replace Dr. Gupta on CNN. He could replace anybody with that brain and that mug. I'm just like, man, oh man, and Sheva, all the things that are possible. So Dr. Chen, can you tell the people a bit about who you are? Because we originally met Dr. Chen during the monkeypox outbreak, and we had the opportunity to speak with him then. But can you tell the people who you are and what PACHA is? And you know how these things go.
Yeah, so first off, thank you so much for the kind introduction there. Appreciated. So my name is Phil Chen. I'm an infectious disease doc. I'm sitting right now up here in Providence, Rhode Island. I'm part of the Brown University Health System. I'm also chief medical officer of an LGBTQ clinic that I started in 2020. So I've always believed in the power of community, and I practice myself. I'm a practicing physician in the community as part of this clinic, which I started. And I'm a new member of PACHA. And first off, I just want to thank you all for hosting us down in West Virginia. I'd never been to West Virginia. I've been to lots of other parts of the U.S., but I'd never seen Appalachia as I did in West Virginia. So thank you all for hosting. I learned a lot. I want to first off say that it is so inspiring to come to some of these places and see people on the ground doing the good work. So I just want to commend all of you for all the work that you're doing. Saw some amazing places, the Healing House, West Virginia Health Right, obviously community education group, and the mobile unit that we saw as well. So just some amazing people doing work in the community on the ground. That was inspiring. And I'm taking some lessons back here to Rhode Island. So PACHA, the Presidential Advisory Committee for HIV/AIDS, is an advisory group to HHS, to the secretary. It's comprised of a lot of folks from across the U.S. from very diverse backgrounds. I'm representing as a physician, but there's a lot of folks from the community. There's a lot of folks who have HIV, and then there's some other HIV public health folks as well. So I think it's great that PACHA is getting out into the communities to learn about what's going on across the U.S. And I think, what I was struck, and I'm going to provide just my 2-cent commentary with perspective, what's going on here in New England, some of the other places. I've done some work as well down in Jackson, Mississippi with a couple of my colleagues. as well as a number of other places across the U.S. To me, obviously, as I look at the HIV epidemic in West Virginia, really struck by the concentration among injection drug users. And that's not new to any of you on the call, but was new to me, being from someone where the epidemic here in New England is largely, predominantly gay, bisexual men who have sex with men. It's very different in many other places in the US than it is in West Virginia. Up here in New England, in the Boston area, we did have some outbreaks in and around Boston of injection drug use, and this made the news several years ago. And we've responded. Boston, Massachusetts responded. We in Rhode Island responded aggressively with a lot of SSP syringe service programs. And I guess I was a little bit disheartened to hear, and this does not reflect anyone on the call, but just some of the leadership, the political leadership in West Virginia, and just the slow response, I think, to what's going on the ground. And to me, as I was listening to the stories, I think, with lots of you on the call, I think the will is there, the intentions to address this. But to me, I think hearing that, that there's actually been a reduction, for example, in syringe access during, with the HIV epidemic so largely concentrated among people who inject drugs is obviously the wrong direction. So I see some of the major challenges in West Virginia related to policy and just pushing some of these, some of the political leadership, frankly, to be more supportive and to change some of the laws and the funding. I am worried about West Virginia. One other thing that I learned, and I think I asked this question, was about the opioid settlement dollars. I mean, you all have $1 billion coming into the state. That's such tremendous funding and resources. I would be worried that some other folks may have different priorities for that funding. At the end of the day, I think that that's a huge amount of funding to help start some initiatives to address HIV. And I think what you all can do to advocate for transparency and to make sure the voices of the community are heard and how that money is spent would be really critical. And finally, the other thing that one of the other big takeaways for me, I learned what a holler is. Thank you, Tony. And I think one of the biggest challenges in America in general, and certainly in Appalachia, is how to reach the rural populations. And hearing that there's these communities, literally of folks living in trailers in the mountains, sometimes without, electricity. I sort of was always thinking that telemedicine or, technology could reach some of these communities, but I think understanding that that some of these folks may not even have technology, that to me is really one of the greatest challenges of engaging rural America in general in healthcare. And I think, it sounds like you all are doing the great work and training some basically community health workers to go up into the mountains. And I think that's what it's going to have to take, is just a ground game of engaging those folks in some of these communities. So in general, I learned a lot. I'm sort of throwing a lot at you. Those were my initial impressions, but thank you again for all your work, Tony, and others.
No worries. I mean, Dr. Chen, honestly, it's an everybody effort. And I think that one of the things that we certainly did put into our response to PACHA as a kind of action steps, I think we sent like 4 or 5. And I honestly encourage anyone on the call to do the same, is that, one of the things that we said is that we felt like it, and I believe it's a push-pull mentality. I think we talked to you about the work that Tricia and her team are doing on the opioid settlement and creating the dashboard and all of that. And that's more of a tracking and educational mechanism, but we think it's a push-pull, right? If HHS doesn't know what these folks are doing with these dollars, and we are pushing from the ground to say we want transparency, we want utilization with these dollars. We want access to those dollars. We want knowledge about those dollars. But if HHS doesn't know what's happening with those dollars, I think that that's a challenge as well. And one of our recommendations was that HHS needed to be more engaged in the opioid settlement release and what is happening state by state, town by town, county by county. And I do think that that's something that if HHS, they can't have an oversight function just because of the way that the money is, but I think having someone with their finger on the pulse of it would be critically important. Now, I'm going to save her for the middle because if I give her the end, I won't be able to get her back. And that's going to be Nakia. So I'm going to put you right in the middle. So I want you to talk a bit about your program, which people may or may not know, but also just talk about your experience with kind of presenting at PACHA and introduce yourself to everybody on the call who may not know you.
Thanks, Tony. Hey, everybody. My name is Nakia Austin, and I am the co-founder and CEO of the Healing House. We're located in Charleston. We are an emerging nonprofit here in the Valley and excited about the work that we do. We work with women who've been impacted by trauma. A large part of our work is kind of recreating the narrative around trauma. People think that trauma is a life-threatening event and only a life-threatening event. And so we like to help educate individuals on what trauma actually is, which could be anything, right? It's a very wide spectrum because trauma is not an event. It's a psychological and emotional response to an event. And so we first want to help educate people on that. And then secondly, that opens the door for us to help a lot of women in the community. I was introduced to CEG probably about, has it been 2 years, a year and a half? Geez, it's been a little bit. They were one of our first big funders to help us with some projects. And I think in working with CEG, it kind of opened my eyes to some intersections that I didn't even know existed. When we started the Healing House, because our target was just working with women with trauma, we didn't really have a full spectrum of what all we would be dealing with. And once we got into the work and started to see that about 76% of our population are at risk for HIV and AIDS, then that kind of opened the door to, we need to dive into some more of this work. We do have a high percentage of participants who have a history of substance use, because trauma and substance use go hand in hand, unfortunately. And so we've been really, as of late, exploring what can we do to really put more momentum behind supporting our participants who are not only at risk, but who also have tested positive for HIV, AIDS, or hepatitis. So we've been really trying to put our hands around that. And we actually have a strategy meeting next week. Getting the opportunity to speak at PACHA was crazy for us. We are, again, emerging. So that's my polite way of saying we knew. So we are emerging, and not a lot of people know about us or the work that we do. And so as the young people say, it was a huge flex for us to say that we had men and women from all over the country, including the White House, come and hang out with us. And it was a major opportunity. And to be able to present on the panel and kind of talk about some of the unique struggles as an emerging organization doing this work was really, really, really amazing. Not only myself, but my staff got some major takeaways from our time and our experiences with PACHA. And I think that on a personal note, just the way they entreated us when they came into our house, because we actually do our work in a house. So when they came to the house, they were all so amazing. I think like I really had to tell my staff to be quiet so we could go home, because they would not stop talking about it during the debrief. And so they were just really excited to get the opportunity to meet men and women from all over the country who are passionate about doing some of the same work that we do, as well as garnish ideas from them. So we split the team up and let them go into different places in the house with different staff members. And of course, PACHA got to ask questions of us. But they also gave us ideas and suggestions and comments that we have taken to heart, and again are working towards making ways to implement some of those strategies and ideas. So all in all, it was a great experience for us. I hope that we get to do it again. I hope that wasn't the last time that they will visit rural Appalachia. As a big city girl, I would like to say I too had not heard of Charleston, but I've been here for a very long time now. And so I definitely consider it home. And it's nice to be able to have a different kind of spotlight on us. I think that there's a lot of ignorance surrounding Appalachian culture and communities, especially minorities in Appalachia. And so I think it was really awesome that Tony took the initiative to be a forerunner in bringing the attention to who we are as a people, how we navigate in some of our unique struggles, and to show that we are not all kind of how we are portrayed in the media and different outlets. So just grateful to have been on the circuit for the tour and for our opportunity to share with the men and women of PACHA.
Right. Thank you so much. And I think that, you in particular, I think that one of the things that we wanted to highlight was what leadership looks like. in this part of the country, right? And what leadership looks like in Appalachia. Someone asked me kind of unofficially from PACHA, they said, there was a lot of women leaders, whether we're talking about who we had really present on research. And I was very intentional for that to be Dr. Hodder from WVU, to be Lynn, and for it to be Judith. We wanted women to be highlighted who are doing this work. That we wanted to see people of color doing this work. I think that in a lot of people's minds, it's old, stodgy white men only that are here, that are doing work. And I think that, that is why we use the tagline that we do, which is "We are Appalachia." Appalachia is maybe 4% people of color, but the reality is that those people of color are doing a lot of work. And the reality is that the women here are doing a lot of work. And I think that it is about kind of reframing how people see Appalachia. And as I always, we were also honored to have Gail Manchin from the Appalachia Regional Commission come in and present. But, one of the things I always try to talk about is that a part of our job always at Community Education Group is to bring resources, opportunity, and a spotlight to the Appalachia region. Good, bad, or indifferent. We want people to see who we are, what we are, not what you think we are, and to get to know us. And so, again, being able to share your experience, your organization with a national audience is a thing that, again, I think is a part of why we are here. And I think, Dr. Chen, one of the things that you said earlier was, kind of the understanding that this is a different epidemic. And one of the things we try to do here is to always make sure that we're talking about how this epidemic is different, and that we are 30, 35 years into an epidemic, but we don't have an infrastructure of a New York City or of a Rhode Island, of a Washington, D.C., of a Baltimore. We don't have that HIV infrastructure to kind of build upon. So we have to build this thing as we are moving it. And yes, we have to do that in a climate, in an environment. I think that people look at things and they see, well, you've had X number of needle exchange sites close over the last year, or you only have this many MAT providers, and you have this huge substance use disorder crisis, epidemic, whatever you want, however you frame that. But the reality too is that the other piece that we don't talk about is how exhausted a lot of these providers are, how exhausted a lot of these public health officials are, how exhausted they are, because this isn't just some random person. In these small towns, in these small communities, this is brothers, sisters, aunts, uncles, high school buddies, football buddies, college buddies that you may have picked up on your bus from you being an EMT volunteer, or you being an EMT 3 and 4 and 5 times. So there's a piece of trauma, getting to what Nakia does, that we've got to figure out how we deal with on that end too. Because when that trauma manifests itself, sometimes it's a bad policy. Right? Because somebody's tired and they have a bad policy. So all of these things factor into how we have to create a response in 2023 and 2024 that for many people will look like we're creating a response in the early to late 90s. And that's unfortunately where we find ourselves. What is old is new here. What is very old is what is new. And I'm going to let Lynn talk about her experience, but also kind of talk about kind of what the data are showing us at this point in time.
Well, thank you so much, Tony, and thank you, everyone. It was a great day to listen and learn from a lot of folks who had a lot of great experience, both on the ground, but also at that research level. And I think that was what was unique, was being able to hear folks, my counterparts at WVU and what we're doing here at Marshall on research, and trying to really get a scope of what the data is looking like and what it's saying, and how to be more responsive to that, like knowing, we need to track when a harm reduction program or a syringe service program closes. And so that we have a greater grasp on the impact of the politics and legislative decisions on every person. And at the same time, we have to also be ensured that we're working with those folks who are on the ground every day, meeting the direct needs, and know some of those more unique issues that a person might be experiencing that aren't sort of filtering their way up through the data. And so I think some of that is one of the things that we're trying to do here at Marshall right now is like community engagement research, and the idea of having participatory engagement, both in the design and development of a project, but also in the exploration sort of the needs. And so, you know, we might have a good idea of what those things are that the person needs or how they're going to solve that, but we often miss the mark when we ask some like open-ended questions because we're not even seeing that sort of lived experience. And so we were recently challenged by our new president, Brad Smith, who uses a model that he developed when he worked with Intuit, and is sort of based in creative thinking. And he sort of challenges people with this idea of thinking about a project. And he took on basically a company that wanted to do a startup to help individuals open their prescription bottles, specifically if they had Alzheimer's, or specifically if they had rheumatoid arthritis and other issues that were affecting mobility. And so they sent out surveys and they asked people, like, do you feel as though you're able to open your meds? And resoundingly, they were told yes. And so, you know, their funder said, you know, this isn't a project worth doing. And, you know, thanks for your time. And someone said, well, there's actually this other way we could look at the problem. And so they went into people's houses and they said, how do you open your, you know, can you open your meds? And this woman, who clearly, like, her hands, you know, weren't even fully wouldn't open, she could barely open her front door, said, yes, I open my meds. And they thought this was very confusing. So they said, show me how. She took them into the basement. She put the meds under a giant paper cutter and she sliced off the whole top of the meds. And she said, there you go. So her meds are open, but now A, we have an open container of meds, and B, she had found a way to open her meds, but that's not an effective way to open your meds. And that might lead to grandma cutting off her hand as well. And so that sort of challenge, or that sort of way of thinking, has been something he's really pushed us within our research, of saying, you know, we might ask people, like, do you feel as though you have access to substance use treatment? And a lot of people might say yes, because they know there is a place they can get treatment. But in that question, we might be limiting ourselves to all of those other factors or barriers that are actually prohibiting them from seeking care. And we know, obviously, stigma, and we know transportation and childcare, but we also know discrimination and perceived prejudice and racism, and all those other factors may be affecting them, along with other chronic diseases, mobility, just the trauma of going to someone who's perceived to be an expert or a doctor, as barriers and factors to that. And so as I was just thinking about the conversation we had at PACHA, it was a lot of feeling as though we were having to have the conversation from the top down and the bottom up, like, where, you know, everyone's seeing the same thing, but it looks different from all those different perspectives and variations. And so how do we, as as community education, how do we at Marshall make sure that we're asking the question or observing the situation in the right way to actually come up with more unique and adept solutions? And I think one of the things I said at PACHA that I'll always say about Appalachia is things work. If we can make something work in Appalachia, you can make it work other places, but things that work other places don't always work in Appalachia. And so I think we always need to sing that, because people look at us and think, you know, we don't know better, or we're stuck in a holler, or, you know, we have all these struggles and difficulties, including our legislature. But if we can find a way to do this here, we really can help other communities that might have more resources and might have, you know, maybe some more connections, or might have those more academic connections, but they're not going to have that human connection at the same way that Appalachia does to take care of its own. So.
And Lynn, I think you kind of hit the nail on the head for me. I think that, you know, I get asked a lot, like, you know, how do you make it in Appalachia? And I'm like, the reality of that is, what people don't want to hear is that I will never be, quote unquote, from Appalachia, but I get asked all the time, so now what county you live in and how you get here? And what people don't understand is the how you got here question is not they're not asking me, how did I move to Appalachia? They're asking me, what route did I take to get to wherever I am? Did I take a major highway system, or did I take old Route 55, and did I turn down by the Walmart, and did I go by Chucky's garage? That's what they're asking me. They're not asking me anything else. They want to know my familiarity with where I am. But the other thing is that we, not just me, but we, CEG, has been consistent. And it wasn't that we came and like we were some sort of carpetbaggers coming in to try to do something. We said, we're going to be consistent. We're going to be on the ground. And this is about you. This is about we are Appalachia. And I'll keep coming back to that it has not been a thing where we're like, you got to do it this way because this way worked in Poughkeepsie. But we're saying we got to figure out what's going to work here because whatever's going on now is not working. So we got to figure out what is going to work here. And we realize is that we've got to train people from here. We've got to educate the people from here. We've got to incorporate people from here to be able to do this level of work. Now, this guy I've met over probably the last year or two for the work that he's doing, because I think this is the other part of what we've got to do is that we've got to use media. I don't want to say use media, but we've got to incorporate media and the messages that people are getting out about where we are with substance use disorder, where we are with MAT, where we are with Hep C and HIV. And so, Alan, I know that you were at the PACHA meeting, but you really have been doing a lot of, I call it the yeoman's job of trying to tell the story of Appalachia. And sometimes it's telling the story people don't want to hear.
Oh, thank you, Tony. I rely a lot on y'all, so I appreciate that. But yeah, my name is Alan. I am the public health reporter for Mountain State Spotlight, which is a nonprofit newsroom based here in Charleston, covering all of West Virginia. I've been trying my best to cover a lot of substance use disorder related issues in West Virginia over the last year. I just hit my year mark a couple weeks ago. So yeah, I also am not originally from West Virginia, came here to do this type of work. And I was at a panel actually a couple months ago with someone who I think a lot of people on the call know, Dr. Kathy Slemp. She was our former state health officer. And she had this really interesting this slide that I've been thinking about a lot lately. It was titled "The Emotional Life Cycle of Disaster." I asked her to speak on harm reduction in front of a crowd of journalists, and she really emphasized that there's this period of heroism where everyone comes together and works together, and which turns into what she labeled as the honeymoon period, where there's community cohesion. And everyone we heard it in COVID in the beginning, like we're all on this together, that type of attitude. And then comes disillusionment. It becomes harder and harder to be faced with these existential health problems. Appalachia and West Virginia has been in the midst of its substance use epidemic from this third wave of an opioid epidemic for 3 decades now, just a really long time. And then there's working through the grief. I mean, like a lot of people have touched on this, but there has been so much death and destruction in Appalachia. I mean, like you can look at West Virginia's on the CDC's website for the overdose rate, and it's about twice the rate of death of fatal overdoses is about twice that in West Virginia of the next highest state, significantly many times higher than the U.S. average. And Dr. Chan alluded to that we have there's likely to be about $1 billion coming into West Virginia for these the opioid settlements. I think it's important to highlight that is a lot of money. There's no doubt about that. But in a lawsuit a couple years ago against it was the city of Huntington and Cabell County, they were suing the 3 big drug distributors, AmerisourceBergen, McKesson, and Cardinal Health. And they did a forensic autopsy. It was put together by a forensic investigator in Huntington and Johns Hopkins University epidemiologist. And they determined that it would take about $2.5 billion just for the remediation of Capitol Huntington. When you extrapolate that to the rest of West Virginia, it's tens of billions of dollars if you really want to get to the heart of the substance use epidemic. If you really want to address the root causes and support the work of people doing this work. So I think that's really important. With regard specifically to HIV and infectious diseases that come related to substance use disorder, I think it's, the syringe service program, from what I found from my reporting, is it's crippled a lot of West Virginians who really want to make sure to keep people safe. I've talked a little bit with Christine Teague, and she can speak a lot better. So she was one of the presenters at the PACHA group, but she talked about how she's told me before about how, you just can't really expect people to, if you're trying to control an epidemic, you can't expect people to just come and say, here, test me, like I think I'm at risk. There is, in Appalachia, a history of distrust. In the 1940s, Harry Truman promised every coal miner that they would have health care for the rest of their lives. That didn't happen. Instead, they got black lung. So I think that, sorry, I got a little distracted by the chat. But
that's that Trisha throwing out facts again. We like to say Trisha's giving receipts again. But go ahead.
I appreciate you, Trisha. So, I mean, it's going to take a lot of work, whether it's going to take, the HIV, I'm looking at them right now. The HIV diagnosis so far in West Virginia are a little bit lower than they were last year. But again, if this is spread to rural counties that have health departments of 1 to 2 people, McDowell County has 1.5 person full-time positions. It's hard to trust those numbers. So it really is a crisis, I think, and it is. West Virginia has some absolutely incredible people doing some work, like Dr. Chan. I went to school up in the Northeast in New England, and I've been around health environments for most of my life. I was in grad school as well. I've never seen organizers like I have in Appalachia. People who are so committed, so focused on what the stakes are at any given time, and are thinking of innovative ways to address them. But at every turn, it seems like there are barriers that need to be overcome. We didn't talk about it really at the PACHA meeting, but in today and tomorrow, West Virginia University, the other major research university besides Dr. O'Connell's Marshall University, is going to they're going to lay off 11 of their 40 full-time faculty members in their School of Public Health. These are people who, one of them I was talking to a couple weeks ago, is doing Mercer County, which is one of the counties hit hardest by, that's most targeted by the drug distributors, really hit hard by the substance use crisis. He was down there trying to build back any kind of ways to work around the syringe service program when he, as he was dealing, worrying about whether he was going to lose his job. So I don't want to trivialize that. That's going to be a devastating blow to the state as well. There's a lot of, so again, I think there is for people not from here, there's a lot of really incredible work that people are doing, but there are so many different barriers that need to be overcome as well too.
Thanks, Alan. And what I like to see them as, I don't like to see them as barriers. I like to see those as challenges or hurdles, right? I think that one of the other challenges is that we are in a lot of ways what I consider a research naive community. Meaning there's already so few researchers looking at this level of research You know, I know that, you know, like Yale has come in and they're doing a study, but, you know, we certainly do have Marshall, we have WVU, but we have, again, few and far between that are these, you know, kind of academic powerhouses. One of the other thing that we've been doing is trying to work with the CFAR, that's the Center for AIDS Research, at NIH, to really look at both Marshall and to look at WVU as becoming a part of either the DC CFAR or becoming a part of a formulation of what they would call a Mid-Atlantic CFAR network, so that these research institutions, and so folks like Dr. O'Connell, are not out there on their own, that they're also working with other universities, other institutions that may have a larger research budget or may already have R01s from NIH, that we can create partnership. I think that figuring out that piece of this puzzle is critically important, because I think that where research is, dollars follow, frankly. And that's just, you know, my kind of belief around that. Lynn, I want to come back to you on something I feel like is the underlying thing here, which is that, you know, if we talk to the CDC, and we don't want to get into that one again, but if we talk to the CDC will say to us that the HIV epidemic here right now is worse than that of New York City. But then there are a couple of things, right? One, West Virginia, and we're talking specifically now just about West Virginia, was left out of EHE, the Ending the HIV Epidemic. Now, that's one of the other requests that we've made in our letter to PACHA and to HHS and to the Secretary's office, is that we've asked that there, in the fourth pillar of the Ending the HIV Epidemic strategy, there is an outbreak provision in there that says that when an outbreak occurs, dollars, in fact, should follow. Now, it doesn't say you've already got to be a part of EHE, doesn't say that you've got to have X number of cases, but the reality is that our cases have doubled over the last few years. So can you talk a bit about impact on with surveillance, with dollars, with numbers? Help us understand a bit about where we are here with HIV, and if you want Hep C, because I know you were very instrumental in the Hep C elimination plan as well.
Well, I think there's the problem is we don't know, and I think that's the problem at the end of the day. We don't know our rates accurately, and you can't treat what you don't know. And rates continue to spread when you don't know, because we're not putting preventative measures in. And in fact, when we are dealing with unsheltered individuals, unfortunately, we're not able to follow up on medications and viral treatments that we know to be effective. And what the treatment that is really required is, you know, we know what to do. We know how to treat hepatitis. We know how to treat HIV. There are effective preventative measures that everyone could be on who is in a risk engaging community. Our health departments are staffed with very smart people, even when it is just 1.5 of them. There are great people who really know their community and know those who are at risk. Our peer resources are a huge benefit of knowing who's at risk and who is engaging in risk-taking behaviors, because they're on the streets with those individuals daily, and they're the only people who are going to build the relationship that's actually going to move them into care. I think we know, you know, I haven't seen, data is always lacking and sort of falling behind on sort of any of the tracking. I know in like 2021, we had just shy of 150 new diagnosed cases across the state of West Virginia. And so, you know, what's always difficult in West Virginia is then they give us the per capita rate. So, you know, whatever per 100,000, and suddenly we skyrocket up to the top, whereas a major city might have had 9,000 new diagnoses or might be facing these much higher rates. We also know that in West Virginia, it ends up clustering around at-risk individuals, especially, you know, an LGBTQ population, and they're more likely to move to a safe place in the state. And so we know that those numbers have gone up in a place like Cabell County, because Cabell County is the only, or was the first county in the state to receive 100 on the West Virginia, or the National Health Policy Index, for the treatment of LGBTQIA. And so when you have that sort of move, you also end up having individuals moving to where there are services that can assist them and have an active health department that does have an active syringe exchange right now, and does have a homeless coalition. Thankfully, it also means that we do have a hospital or the medical network that is able and willing to treat, but then you end up with transient individuals as well. And so I think when you look at big cities, Atlanta, LA, New Orleans, like those have very high rates of HIV/AIDS, but they also get extensive funding and they're expanding their services. We unfortunately are consistently shutting or making those services harder for someone to get. So ideally, I know there's a lot of folks working on this both at WVU and at Marshall's Medical System of trying to consolidate infectious disease treatment under sort of regional experts, and then either be able to do echo sessions to share that information with regional providers, or telehealth sessions to share that information with regional providers. But one of the biggest pieces is so much of that data is protected and is not then shared readily, even in a health record or with those folks on the ground. And so I will share that we are working on a project that is trying to touch this a little bit. It won't yet fully enter into infectious disease, but it will, is the first attempt that we are making at sharing some HIPAA and 42 CFR Part 2, which means substance use data across the health record using the West Virginia Health Information Network, the WIN. And this is a project with the city to try and start tracking people that are both unhoused, who enter the system, who then may flag and then get flagged for either risk-taking or active infectious disease. And then if we can start collecting their data from day one, we can move them more rapidly to, for example, a hepatitis C treatment that most insurers will not allow coverage for until you have 6 months of sobriety. But unfortunately, our doctors aren't often talking to our substance use treatment folks, and that data is so hard to get. So that person might reach those 6 months and then still is not getting treatment, or it might take an extended period of time for all of that data to get to the right person to then lead to treatment. And so anything that we can do to reduce that barrier, and on 6 months and 1 day, they can go in and start treatment for hepatitis to stop that spread, that's really what we need to be doing.
And Lynn, let me ask you this. Do you think that we can get MAT providers? Because that's kind of, I think, my goal, my mission is to get MAT providers to either be able to, let me rephrase the question I'm going to ask. What do we need to do, in your estimation, to get MAT providers on board to be able to do that screening at 6 months? Do we need to change the law where you're required to have the substance use, quote unquote, clean time of 6 months? Do we need to eradicate that? Other jurisdictions have gotten rid of any sort of sobriety requirement. Is that what you think? Or, you tell me.
No, I think anytime that unfortunately insurance or payment structures are limiting an individual's access to treatment, that it's now removed from the physician and the individual's ability to access care. I understand that these are costly drugs. I'm not, minimizing that and the fact that we want to ensure that people are on effective treatment. But if a provider says an individual should be ready, willing, and able, then I think that provider and the individual should have the ability to start that person on a life-saving changing medication. Also, any time of that person having that eradicated in their system is going to reduce the ongoing spread and that risk taking, that their risk to larger community. And so I think, as we all know, the idea of public health is also community health. It's ensuring that you're not just taking care of the person you're treating, but by reducing their risk, you're reducing our overall risk. And so, what can we do in those counties to ensure that those people are having the ability to talk about that with their provider and get immediate care. So I think it just depends on, what that might be. Diana says she's not aware that people needed 6 months in that. For most providers for payment structure, there is a limit around that 6 months for certain insurance capacity for a person to get care or to get their to get the medication paid for.
Right.
I mean, Melissa, I know that we faced this last week.
Right. Melissa, this is way too much for me to read and to synthesize. Can you say what you said in the chat out loud?
Absolutely. I'm just curious. I'm a West Virginia resident. We work in West Virginia, but we also, I drive 10 minutes to my office in Maryland. So our organization does a multitude of things. I'm just wondering how border counties are being looked at, because while we're funded by the state of Maryland, we don't turn anyone away. And we know that we're seeing people from West Virginia, especially the unhoused populations, low income. We have began doing HIV, HCV, STI testing. We have now a recent cluster, from what I'm understanding, in our region of HIV outbreak. We also have syringe service programs, so we're constantly talking about it. We literally know people are coming across what we call the Blue Bridge for services from us, which we're not going to turn them away. But there has to be, like, how are we approaching that as well? Because I think that that's a really important structure to look at. The state of Maryland, the CDC called the state of Maryland, called us and wanted to know, are we helping people in West Virginia? Yeah, but how do we get funding for the people in West Virginia to be able to follow up? Luckily, I have a connection. We've been able to connect with our local hospital, our health system, UPMC, so that it's a regional approach, not just the county health department in Allegheny County. So folks can go to UPMC for services. But it's a really crazy, like, we're trying to jump through hoops and loops and figure it all out to help these folks. So I think it's just something to also, I know we're not the only county that's a border county.
Well, I mean, that's just it, right? So, over 40%, like closer to 44% of all Appalachia counties touch on more than one. I mean, and so that's that, and that was one of the other issues that was actually in our response to PACHA, was to say that we've got to figure out how we're going to let money move across state lines and across county lines, and that the rural health calculator may have outlived its usefulness in this context, right? Take an organization like yours. If I put you in your address into the rural health calculator, it may be that the money is for across the road because that's the county line. But the truth is that folks are coming across that blue bridge, and they don't know, they don't care what county you're in. They just care that you've got the service that they need. And so we've got to really figure that out. But I believe it is going to take federal intervention to say, you can move that money from Maryland to West Virginia. You can move that money from West Virginia to Maryland. I also think that it is going to take more than, us and the National Rural Health Association saying this is a change that must happen. And I think that the other piece is that what happens, I had a conversation with folks from HRSA who said, the reality for us is that we believe that the rural health calculator helps us figure this out based on per capita, what's happening, kind of neighborhood or kind of community, what's happening. I'm like, but that's not how our communities work. It just doesn't work that way.
Well, and then you add in even our Pennsylvania, we can be in Pennsylvania from my office in 15 more minutes. So we're getting the Pennsylvania who's coming here to get in a lock zone anytime we do an outreach event because they don't want to have to pay for it. I mean, and it's totally fine. But I do, like, I can't emphasize enough, and I know I'm preaching to the choir right here, but I can't emphasize enough how important that is. And if I can help in any way, shape or form, please do not hesitate to reach out, because that's what we do.
Right. I mean, and I think that that's exactly what it's going to take. I'm going to give you all of the names of all of the people that we wrote to at HHS about this, and hopefully you'll write them an email about this too. But I think folks don't know it's a problem until they know it's a problem. And what happens often is, I think that Dr. Shan said it earlier, that it's kind of like coming here, you get to see here. I can't tell you how many people from PACHA said to me, this isn't what I thought West Virginia was. And I'm like, well, what'd you think? And nobody really wanted to say what they thought. But I think that I don't think many thought that there was no one here that could string a sentence together. I think that they thought that there were people who really could not and did not care. And I'm like, that's not what's happening here. We are low resourced. This is not a lack of ability. This is not a lack of cause. This is not a lack of community. This is not a lack of organization. This is in many instances a lack of resource. That's what this is, and a lack of attention. That's why it's critically important that everybody who's on this call, when you got something like we're talking about with this multi-state stuff, that you're writing to your member of Congress, that you are writing to HHS, you're letting the secretary know, here is a problem. If we can fix this problem, I can address public health. I think that the work that Lynn's doing with really trying to organize and create more community researchers. All right, how do we address the fact that we are low barrier in, so many other areas? Well, we're going to have to build it. And that's what I kind of tell folks at CEG all the time. If we build it, they will come. But the truth is sometimes we have to build it with no resources. And we can't always do that, but we have to do that. That's the only way we get to where we are, is that we build it, because it needs to happen. And we have to figure out, unfortunately, the money part. And again, that's because that's who we are here. You're not going to let, there's a lot of things, yes, there's racism here. Yes, there's sexism here. Yes, there's homophobia here. All of those things are here. But the reality is that I can tell you one thing that's not going to happen. You're not going to let me go hungry. You're not going to let me go unclothed. You're not going to let me go unhoused. If you're eating, I'm going to eat. And that's the reality. Dr. Chan.
Yeah, thank you for those words. I'll just a question for the group. So I just wanted to respond to Dr. O'Connell's comments about research, which I think is great. I am part of our local CFAR up here at Brown, and I think that getting CFAR and some other of the networks is a good way to help build up some infrastructure, some brain trust, and just training like the next generation of researchers, training those people to who can get out into the community. So I'm happy to help with that. The other option I think as well would be engaging the CDC. Have you ever had like an epi aid to West Virginia to come in? I see some nodding heads. Yeah. Sometimes I'm not sure how long ago that was, but the CDC does have the potential to direct more resources. And sometimes I think having some of these folks come in and at least provide to maybe the policymakers, et cetera, about what would be some best practices that have worked in other places, like Scott County, right? Indiana has done that, and they were able to ramp up some of their syringe service programs. So anyway, just a thought there.
Thanks. Yeah, and that's right on. I think the last time around we had a little hiccup when Dr. Dakalakis gave a presentation. So I think what we're going to try and figure out is kind of exactly that. How do we get it to be more focused on an outcome rather than a generality? But that's just my take on that. Lynn, I'll let you respond to the research question.
No, I definitely appreciate that. And yeah, I agree. We've been working with some partners on trying to expand it, but I can definitely reach out to you and just anything that we can always do to expand, because, every time that we face issues, the resources, you have to fund the research, but you can't prove the problem without funding the research, but you can't get money for the problem or the research right? Like, so we're always chicken and egging it. And like Tony mentioned, we always try and do it on those low resources, but ensuring that we're building. Our major goal with the university systems is to ensure that the next generation is both invested in West Virginia and then staying in West Virginia to help be part of the solution. But I think, and I hope that research and evaluation and effective programming is one way to do that, as people find hope in their community and see themselves as part of the solution, which I think is, unfortunately, when you're dealing with diseases of despair and you're dealing with negative images of your community, it's hard to want to stay or to want to move here. And like many have mentioned, I'm not from here either. So, and I'll never be from here, but I'm allowed to stay for now until they kick me out. But yeah, we did have an epi aid in Huntington who did some great work with our health department. So I think, that was beneficial. It's just, it's a difficult climate for some of that with our legislative staff.
All right. And I think that's it too, right? I think that, I was at a meeting recently, and I'm probably going to end on this. I was in a meeting recently, and one of the questions was about, what do we do for best practices in harm reduction? And it was a meeting with some funders and with some other national organizations, and they're talking about rural communities. And so one person said best practice was certainly to have the federal government resources be able to be used for syringes. Another person said that it would be safe consumption sites in any jurisdiction that wanted them. Somebody else said that it would be to decriminalize all drug use. Now, this is one of those moments where I realized I wasn't sure if I had just been in West Virginia too long or I had just honestly become this conservative. But one of the things that happened was that I said, I feel like the best harm reduction practice and model that we can use right now is to be clear about the geopolitical climate that we are in, both domestically and internationally. And I don't know that there's a whole lot of bandwidth for using federal funds for syringe access. I don't know that there's a whole bunch of room for safe consumption sites right now. I don't know. But what I think we can do, is flip this and turn this into a model by which we're talking about economic development, workforce development, turning those policies that I think some people see as challenging, turn those into, let's get people back to work. Let's talk about how it is that it's not that we don't have jobs available. We have people that not at those jobs though. And what we can do is that, we can get people up to those hollers, but we've got to train people from those hollers to go back to those hollers, because I can't go in that holler. Lynn can't go in that holler. Alan can't go in that holler, but somebody from that holler can go back up in that holler. And maybe what they can take up into that holler is, let me show you how a rapid HIV test works, how a rapid Hep C test works, how a colorectal screening works in a box. Here are all of the things in which these folks need to probably come down for and get support for, but can't. What we've got to do is figure out how to change what the game is. And right now, if we keep kind of running at this thing like Don Quixote, we're going to make them accept a policy. That's not going to happen right now. I just don't see it happening right now. But what I think we can do is make small incremental change. And one of the most important ways that we can change that is to do the work in community, to educate community, whether that's the individual consumer, whether that's the provider, whether that's the local and county health department. Alan hit it. Most of these county health departments that we're talking about are 1 to 5 people. This isn't an LA health department, or this is a small amount of people. So we've got to see them as a part of our partner network. I think like the work that Nakia is doing to get women healthy and whole and to see themselves as healthy and whole so that they can be a part of these networks is critically important. So, I, want to say that I think that it takes all of us. And that's why I always say we are Appalachia. Appalachia is this diverse group of people, smart folks doing academic work and academic learning, and learning and teaching like Lynn does. You go to Lynn and you say, hey, what's this mean? And she can explain it to you like you too, because sometimes she knows that that's how I need it. Nakia, who's doing what I think is, really God's work of saying, you are not broken. You just have some pieces that we all need to put back together. And I think, like Dr. Chan's doing his work up there, but saying, hey, I want to be a part of a broader public health response in this nation. And is doing that. He does calls like this and does other work that many physicians do not take the time to do, people. They just don't. And Alan, who is writing about how it is that we as a state and how it is that we as a region of the country need to be seen, and is shining a light, again, that spotlight on what it is that we're doing in the Appalachia region and what we need in the Appalachia region and what is happening in the Appalachia region. We got here because of John F. Kennedy and him framing out what some of the challenges were for us around poverty, education, welfare, and transportation. And frankly, many of them are still here. But I feel like together, we can get beyond those challenges. again, I'd like to thank you all for taking your hour out to chat with us, and hopefully learn a little bit of something, listen to us yammer for a minute. And Melissa, I'm going to be in touch with you about some other things we're doing about this interstate work, which I think is a big deal. Again, thank you all for taking time out, and thank you for all that you do. I'll talk to you all soon. I'll talk to you next month. I don't even know what we're going to talk about next month. I think maybe the Violence Against Women's Act. I don't know. There you go. All right. See you.